Welcome back, everyone. This is Michelle Iandurio. We're pleased to have you back for our last session of the day. We heard that the workshops were well attended and quite interactive, so thank you so much for your participation. So far, we've had 620 live participants to the program today, so really excellent attendance. So thank you, all of you. I'd like to now introduce Dr. Raphael Landovitz, who is Professor of Medicine at the UCLA Center for Clinical AIDS Research and Education. He's also the co-director of the Center of HIV Identification, Prevention and Treatment Services, and has led combination prevention intervention studies and projects using post-exposure and pre-exposure prophylaxis strategies for MSM. We're pleased to welcome him as moderator for the panel discussion, The Data-Free Zone, Tough Cases in HIV Prevention. Thank you so much, Dr. Landovitz.
Thank you, Dr. Iandurio. I am going to try to share my screen here. And I just want to thank IAS-USA and the Ryan White Clinical Conference for allowing me to entertain you all, hopefully, with this presentation. We're calling this the data-free zone because we really sometimes don't have great data for a lot of the clinical situations that we're going to be talking about. You have to still make good clinical decisions. And in order to help us make these good clinical decisions, it's an incredible honor to have this really esteemed panel who's going to help us make some decisions about these cases we're going to be talking about today. We have with us Dr. Doug Krakauer, who's an assistant professor of medicine and population medicine at the Beth Israel Deaconess Medical Center in Boston, and also a research scientist at the Fenway Institute. We have Dr. Susan Bookbinder, who's the director of HIV prevention research at the San Francisco Department of Public Health, and also a professor of medicine, epidemiology, and biostatistics at UCSF. We have Dr. Connie Kellum, who's professor of global health, medicine, and epidemiology at the University of Washington, and also director of the International Clinical Research Center at the University of Washington. We have Dr. Mike Sag, well known to you from his previous presentations. He's professor of medicine at University of Alabama, Birmingham, associate dean for global medicine, and the Jim Straley Chair in AIDS Research. And we have, of course, our very own Dr. Michelle Iandurio, who's one of the co-chairs of this course, an associate professor of infectious disease at University of New Mexico. They will be leading us through this exciting clinical discussion. These are my disclosures. These are our learning objectives for today, which I believe are also in your handouts. And just to remind everyone, people who know me know this is one of my favorite slides. This is reviewing the placebo-controlled efficacy data for TDF-FTC oral PrEP based on population. And the idea here is each of the figures represents the sex at birth of the individuals enrolled in the study, and how full each figure is. In blue is a representation of the point estimate of the efficacy that was observed in the clinical trials. And you'll notice in the lower right corner, our little French guy wearing a beret who sort of looks a little bit like a mime. And I apologize for that. Is representing the IPERGAY study. It was coincidental that he looks like a mime. The striping is to indicate that this was not used as a daily intervention, but instead as an on-demand pericoital intervention. And you can see the wide variety of point estimates of efficacy across these populations. And of course, what we've learned subsequently is that the efficacy is highly dependent on the adherence. And of course, now we have a whole second generation of PrEP agents, including a vaginal ring that just achieved licensure through the European Medicines Agency for vaginal protection against HIV in women on a monthly basis. And of course, TAF-FTC for non-vaginal exposures in the Discover trial. And we'll be talking a little bit more about all of that today. And of course, the data showing the high level of relatedness between efficacy and people's adherence to the study products. So I think we all can agree that we have guidelines that are helpful and that PrEP is in general straightforward when someone has a good creatinine clearance and they don't have a history of osteopenia, osteoporosis, or non-traumatic fractures. Their hepatitis serologies don't suggest that they have active hepatitis B, and they're willing to come in frequently for evaluations, which of course is all of our patients, right? No patients that we ever take care of fall outside of these complexities. And of course, no one has any medical comorbidities. So the straightforward base case is representative of a lot of our patients. And of course, I'm being a little facetious there. So each of these is going to be a case of where that's not the case. So the first case, I'm calling beans, beans, and nothing but beans. So we're going to be talking about kidneys. And this is a 50-year-old man who has type 2 diabetes, chronic kidney disease stage 3, and hypertension, who recently started a new relationship with an HIV-infected man, and is seeking advice on how best to avoid HIV infection himself. His partner admits to struggling with taking ART regularly, but says he's mostly adherent and does not like to use condoms. 1 month after initiating PrEP, and let's assume for the moment that we initiated TDF-FTC PrEP, his creatinine clearance dropped to 55 milliliters per minute. His urinalysis is normal, and his safety labs are rechecked and show that his creatinine clearance declined further to 50 milliliters per minute. So now we're going to have an audience poll question. This is our first question. So your best advice regarding what to do with his PrEP is to continue daily oral TDF-FTC, recheck in a month, switch to event-based or 2-1-1 dosing of TDF-FTC, to dose reduce his TDF-FTC to 3 times per week, to switch to TAF-FTC daily, or something else. We'll now give you all a chance to respond to that poll. Okay, we have responses coming in. Okay. So looks like we're getting a large number of people who want to switch to TAF-FTC. And looks like we're coming in a little slower now. So we can go back and push out the responses to people in the audience and show that. Okay. And I am going to now toss it out to Dr. Iandorio. What do you think? The majority of the voting audience wanted to switch to TAF-FTC. What would you do?
Great. So one thought I would do is maybe the something else first, which is to ensure that the decline in their renal function isn't directly related to the tenofovir, because if there was evidence that there was specific tenofovir toxicity, then I'd be concerned about either formulation. But let's say it was his other underlying condition, I would feel comfortable with either 2 or 4, either switching to the event-based if that made sense for that particular patient based on how many condom-less interactions they have, or I would consider switching to the TAF-FTC since it can be used with a creatinine clearance of 30 or higher.
Yeah, Susan or Connie, what would you guys do?
Because we know that people who are older and who start off with a creatinine clearance that's under 90 are going to be at greater risk of developing renal disease. So while I think of PrEP as TDF-FTC, unless there's a specific indication to go to TAF-FTC, I think he's bought his other indication to go to TAF-FTC. My understanding also with the 2-1-1 dosing is that there's still about the same amount of renal impairment with the 2-1-1 dosing as there is with daily TDF-FTC. So, and given that we don't know how frequently he's having sex with his partner, 2-1-1 PrEP becomes basically 3 times a week or 4 times a week PrEP if people are they're taking 4 doses a week if they're having sex at least once a week. So my preference would be to go with TAF-FTC daily.
Yeah. Connie or Doug or Mike, anything you wanted to bring up different?
Yeah, this is Connie. I would agree with Susan's approach there. I mean, he doesn't have just one, but two comorbidities that put him at higher risk of having renal insufficiency, both the diabetes and hypertension, plus his age, and given his starting point with creatinine clearance of 55, dropping to 50 with recheck, it seems like he is in that group of individuals who would do better with TAF FTC. And I agree with Susan too that I don't think that really from the data we have that event-based dosing has less renal toxicity. So I think he meets my criteria for thinking about TAF FTC.
Yeah, Riff, I'd add one extra thing to the 211. I'm a little bit worried about the 2 because he could have a high peak level of TDF in the plasma, and that could actually make his renal stuff worse, even if he's only taking it every 10 days or so. So I'd go with 4.
Yeah, Doug, anything that you wanted to add to that?
I totally agree with what people have said. The only thing I think is kind of a data gap that would be helpful would be to know a little bit more about people who use 211 on a truly occasional basis, because the data we have in terms of renal outcomes from the original 211 studies were, as people have intimated, were people who had been using an average of 16 tablets a month. So they were effectively using kind of half daily dosing. So if someone truly used this once in a great while and their drug exposure were much lower, I think many people have hypothesized you might see potentially fewer renal effects. But we don't have those data, and I don't know that they're coming anytime soon, which is why I would also definitely land on 4 for this one.
Yeah, so thank you. I generally agree with everything that's been said. I think looking for other etiologies of his renal dysfunction, is he on an ACE inhibitor, is he on any other nephrotoxins, would be an important part of that workup. But I do want to just briefly look at some of the data that support the points that you all made, and then come back to Michelle's point about the 211, which, with all the caveats, I do think is a little provocative. So I want to come back to that. Also, I think some of the data that Susan initially referenced, we know that people who use TDF FTC with greater fidelity have greater decreases in their creatinine clearance. We know that older individuals, which makes me sort of cringe, being defined as over the age of 50. Now that I turned 50 this year, I guess I'm now old. And people who start with creatinine clearances below 90, all at increased risk of dropping creatinine clearances. And again, the data to support in the open label extension study of IPERGAY, again, that older individuals at greater likelihood of having declines in their creatinine clearance. And again, a dose-dependent effect. So again, coming back to what Susan and Connie were pointing out, that with this increased use and the increased fidelity of use, which we want to encourage, paradoxically has this challenge of having increased declines in creatinine clearance. And now there have been a handful of cases, this is just one case report, of Fanconi syndrome having developed in TDF FTC in a non-HIV infected individual, which I think is an important thing to keep in mind. It's our most feared complication of the use of TDF in people living with HIV, but at least until fairly recently, there hadn't been lots of reports of use in the PrEP context absent HIV, but it can happen. And I think, again, as Michelle said at the beginning, looking at the urinary sediment and making sure that there isn't evidence of a Fanconi's presentation, which might make you much less excited about tenofovir-based PrEP preparation in general, it's worth considering that it can happen also. Of course, the data that supports all of this that we've been referencing is the Discover study, which was a randomized trial of TAF FTC versus TDF FTC in MSM or transgender participants, where people were randomized and followed for incident HIV infection. And the primary result, of course, was one of non-inferiority of the TAF FTC compared to the TDF FTC, both with very low rates of incident HIV infection. The take-home message being, of course, both products work well. But I think what we all are marinating about is in using these extremely sensitive markers of renal function, the TAF FTC looked more advantageous than the TDF FTC, although, we keep coming back to the issue that the clinical outcomes were not different in these arms. And I think that's important to remember. It was shorter term follow-up, and it'll be interesting to see if that's borne out with longer follow-up. But at this point, it appears to be a laboratory marker. And just coming back to Michelle's point about the 2-1-1 dosing, cross-study comparisons are fraught with bias. And, we're always taught never to make cross-study comparisons. That being said, I'm about to make a cross-study comparison, right? And if you looked at the changes in renal function in people when using on-demand dosing in the IPERGAY study, there was not a difference in the declines in creatinine clearance in the TDF FTC compared to the placebo arms. And of course, there has been such a difference observed in the randomized controlled trials of daily oral TDF FTC versus placebo in a variety of populations. Now, again, as Doug pointed out, these were people who were using TDF FTC at fairly frequently. So perhaps that gives us a little bit more confidence that there may be something here. But again, as Susan and Connie pointed out, these cross-study comparisons are fraught, and depending on how much someone is using it, it really may be tantamount to daily use anyway. So I think if someone is having infrequent sex, and it's predictable, that this is something we could think about doing if there was some reason we didn't want to go to TAF FTC, either because of cost concerns, coverage concerns, or other reasons. So just something to think about, and I always sort of go through my mind whether this should factor into decisions or not. Let's move on to a second case. This is called Broken Dreams. And broken because you can tell I'm a fan of the pun, and we're going to now talk about bones. And the question is, are we putting people at increased risk of broken bones? So this is a 35-year-old man who reports having receptive anal sex with 2 to 3 different partners each month, and he's eager to start PrEP. He was diagnosed with early osteoporosis in 2015 and has a history of non-traumatic fractures. So the second question to the audience is, your best advice about his PrEP is proceed with daily oral TDF FTC alone, initiate PrEP with TAF FTC, proceed with daily oral TDF FTC, but recommend vitamin D and calcium supplementation or something else. And we can now go to that poll. Okay, people's answers are coming in. If I were Mike Sag, I would be humming you a tune right now, probably something from a Broadway musical.
I can add that in if you want. I'm sure we're violating. I'll just play it off my iPhone here.
I'm sure we'd get in trouble with copyright violations if you did, right? I mean, if we play something that is, got restrictions on it. Yeah. Okay. So it looks like we've slowed down. We can push out the results. Looks like the majority of people wanted to switch to TAF FTC, but about 20% of people were excited about the vitamin D and calcium supplementation issue. Susan, what do you think?
Well, here's another situation in which I guess first I would start with, if he was actually diagnosed with early osteoporosis 5 years ago, then he was diagnosed with osteoporosis at age 30. And I'd like to do a workup to understand why he's got osteoporosis in the first place, presuming that his provider has actually already done that. This is another situation in which I think people might buy themselves TAF FTC. The difference in bone mineral density is really minimal between TAF FTC and TDF FTC, but there is some difference, and there are some people who have more bone loss with TDF FTC than the average. And so in that situation, I would go with TAF FTC. I might still recommend calcium and vitamin D supplementation for him. So maybe that's the something else, although I'm not sure. But I think I would feel most comfortable with TAF FTC as his prep medication of choice.
Yeah, anyone want to weigh in on what they feel about recommending calcium and vitamin D supplementation in the PrEP context in general, either with TDF FTC or TAF FTC?
I don't normally recommend it for PrEP alone, but I don't think we have. Actually, I don't know if we have data at this point. We may have data at this point, but I don't think that the minimal amount of bone loss that we see with TDF FTC is pretty minimal, and we don't see any increase in fractures in any of the studies that we've seen to date. So it's not clear what the clinical ramifications are of that bone mineral density loss. Also, what we see is when people go off of their meds, they do seem to rebound to pre-PrEP levels. So I don't think we're doing any permanent damage to people while they're on PrEP.
Yeah, Susan, I completely agree with you. I think the one population in whom I do worry about a little bit is youth, right?
Yes.
Who still may be accruing bone mass, and then the ATN data suggests that maybe they don't quite come back to their previous baseline. That's the one population which I still have lots of anxiety. But Mike, I interrupted you.
No. I had three quick things. One, in this story, I would be surprised if he wasn't already on vitamin D and calcium with his history. But the second thing is that, bone mineral density was originally calibrated for older people. I think that's older than the age of, I define old as 15 years more than my current age. So for you, it would be 65.
I like that.
So, but an older population. So I don't know what in the world a DEXA scan means on a 25-year-old, for example, but that's another point. But, I'm jumping ahead, I'm sure, but I would have picked something else if it were approved, and that would have been cabotegravir, which might be a great choice for him, but I'm sure that's a future case.
We are going to be talking a little bit about cabotegravir. Anyone else, Michelle or Doug, did you want to weigh in on other considerations here?
Before we had TAF, as an indication, I think some people would avoid PrEP, and my point I usually make is getting a new infection with HIV is really bad for the bones, and so I think it's risk benefit, and so I would either way recommend that he get on PrEP.
And Doug,
I agree.
Else? Yeah.
Everything people have said. The only thing I would add is the challenge here is unlike with kidney function, where you have a creatinine, which is something that you can assess quite readily. We do it relatively frequently. It's part of routine care. The guidelines and the data around even using a DEXA scan in general is not to really do it unless you have a unique situation like someone who fits this bill with previous osteoporosis or high risk factors. So there's a big waiting game here too. How frequently would you repeat the scan? And so you could be going for a year or two. I probably would check in a year with someone with this intensity of osteoporosis, but you'd be going a long time and potentially doing subtle bits of harm. So that makes it more anxiety provoking on the provider side, which is why I would love cabotegravir, but also would definitely use TAF here.
Right,
Yeah.
I was going to say, sorry, there is a study that's ongoing, should have results in the next year or so, about bone mineral density in young women who are on both Depo-Provera and PrEP. And I think that's going to provide more data on whether or not we should be more aggressive in young women who have who are starting Depo-Provera when their bone mineral density is not fully at adult levels and or on PrEP. But I think that I agree with a lot of the points made. I think I would not, and most people, the bone mineral density issues are not really ones that I would think about. He's in a very different category, being male, young, and with already pretty profound osteoporosis. So I would probably follow him more aggressively, and hopefully he may need other agents than just vitamin D and calcium for his osteoporosis.
Yeah, thanks everyone for that really thoughtful discussion. It was sort of fascinating that this actual individual, who's a patient of mine, actually didn't want to go on TAF FTC after a sort of very sort of nuanced discussion of the benefits and risks. And the overwhelming concern that he had was if he was actually going to gain more weight. And that was a deal breaker for him. So it was a fascinating conversation. And so it was a very complicated interaction with his endocrinologist and him to sort of come to sort of a resolution about how we move forward, because he was ongoingly at elevated risk. And I agree with Michelle that, you know, getting HIV would have been a disastrous outcome for him in this context. But, you know, we've already talked about the data, and Susan mentioned there are these small but, you know, observed differences in declines in bone mineral density seen in the TDF FTC placebo-controlled trials at both the spine and the total hip. And again, as Susan mentioned, that, you know, 6 months after stopping treatment, the evidence by DEXA did return to baseline, the one exception being in youth in the ATN 117 study. And I think we worry about youth who are still potentially accruing bone mineral density until age 25 as a particularly unique population where we want to be very sensitive to this. And, you know, the question of bone mineral density loss being attenuated by vitamin D and calcium, you know, I think at Dr. Sagg's institution, Dr. Overton, who, if anyone was not on the breakout session this morning, amusingly, someone mistook me for Turner Overton, which is only the most flattering thing that could have happened. He and colleagues through the ACTG led a study of vitamin D and calcium supplementation in people living with HIV who are taking a tenofovir, albeit with a favirenz-based regimen as part of their HIV treatment. And calcium and vitamin D supplementation mitigated 50% of the bone mineral density loss in that population. So I think that's where the origin comes from, as us potentially being excited about trying to mitigate bone mineral density loss using calcium and vitamin D supplementation. Although to date, the data have been lacking, really limited to this marker of bone turnover study that was done by the USC group as part of an open label PrEP demonstration project where they just used vitamin D supplementation and was able to show salutary improvements in markers of bone turnover with 4,000 international units a day of bone turnover in the PrEP context with TDF FTC. Again, whether this is going to have clinical impact or not, really unclear. And I think Susan's point is a critical one, that these differences that we're seeing between TDF and TAF, you know, in the Discover trial, again, using these very sensitive measures that, as Doug pointed out, we don't do as part of general routine care. You know, we're fairly small, and although we don't have extended long-term follow-up at this point, there were no clinical differences. So I think it'll be interesting to see as we get more data and more long-term use of TAF FTC in a variety of populations, if there will be clinical outcome differences. But I think, you know, a number of ways to sort of approach this. I was advocating for using TAF FTC with this particular patient, and he wasn't having it. So we'll come back to the other reasons he wasn't having it in a little bit. So thank you for that. So third case, and this one's a little bit of an outlier in terms of things that might see, but I've gotten a number of questions about this, and we actually saw a patient in this setting in our clinic. So this is called "A kiss is a terrible thing to waste." And the key point in the pun here is the waste part. So this is a 28-year-old man who was referred to the clinic for PrEP. He was diagnosed with obesity, hypertension, and sleep apnea. So he underwent a gastric bypass surgery 6 months ago. Since the surgery, he's been eating clean and been taking several vitamin supplements because, of course, there's vitamin wasting when one has gastric bypass surgery. And his supplements include vitamin A, B3, B6, E, ginkgo biloba, and milk thistle. So the question to the audience is, how do you instruct him to optimally use PrEP? now that he has a gastric bypass. Use daily oral TDF-FTC, use double dose daily oral TDF-FTC. Mike Sag already brought up some concerns in someone with renal dysfunction about doing that. Use on-demand 211 TDF-FTC. Do you use TAF-FTC or something else? We can take that to the audience to see what you would do. Mike, did you want to just hum sort of non-trademarked, you know, old standards that wouldn't get us into trouble? You're on mute, Mike.
Yeah, so I have Hamilton behind me. I could say, you know, and Alex got better, but his mother went quick or something like that.
You could, but you know, now that Hamilton has been aired on Disney Plus, the Disney people might come after you. So I'd be careful.
Gosh, yeah. I guess so.
Mickey and Minnie are going to be at your door in a few minutes. Okay. Okay. We can, I think, push the results out to the audience. Looks like we have a little bit of a split here. We have about half people wanting to use TAF-FTC. We had about a quarter of people saying just keep them on the daily oral TDF-FTC, and then a handful of people saying something else. Okay, so let's turn to Dr. Sag and say, Mike, what would you do here?
You know, I wouldn't double up. That doesn't make a lot of sense to me. I would say that maybe the TAF-FTC could be the way to go. I know that there's weight issues. You know, we could talk. I don't think in this case, cabotegravir, if that was something else, probably wouldn't help us too much because that's also associated with that. But maybe the 211 would be the way to go. That's might be the answer.
So we'll come back to that question of cabotegravir and weight gain. So hold that thought.
Well, that's right. I saw that study. Yeah,
I do know a little bit about that study. But anyone else have a different viewpoint? Mike's sort of favoring TAF-FTC, but doesn't quite like the double dose idea. Anyone else have feelings?
Raphael, I probably would engage in a little bit of shared decision-making here about the two daily oral TDF versus daily oral TAF-FTC options, and probably lean towards line drive right up the middle with daily oral TDF-FTC. It's tried and true. It has a little bit of weight gain, and it's hard to know how that will make a difference in the context of what should be larger and much larger amounts of weight gain after bypass. I'm not sure how to integrate the information about some of the supplements that he's taking in terms of the options here. I'm not aware of any particular drug interactions with any of the agents listed here that would make a big difference in terms of the pharmacokinetics and his transit time after bypass. If that may affect absorption, it's all possible, but none of it strikes me as something we have a lot of evidence for. So I might actually reach out to some of the really helpful PharmD colleagues that we have to see if they have any kind of hypothetical way to approach this. But at the end of the day, I'd probably revert back to tried and true TDF-FTC unless he felt strong about TAF-FTC. But I'm not sure there are major benefits here if he doesn't have known bone or renal issues.
Yeah, Doug, I tend to agree with you. And after, you know, a big conversation with this particular patient, that's what we did. We did daily oral TDF-FTC. I'm not aware of any drug interactions with those vitamins either. They were, I really only brought them up as evidence that he does waste nutritionally sort of orally ingested vitamins after a sleeve bypass procedure. And so the concept of potentially reduced absorption of the TDF-FTC is sort of what looms large. And, you know, we did reach out to some of our PharmD colleagues. I agree with you. They're an incredible resource always, but in these nuanced situations particularly. And we reached out to, the company that manufactures, TDF FTC also to see if there were data and looked in the literature. And just to remind people, there are a number of these gastric bypass procedures. On the left, is a more conventional gastric complete bypass where the entire stomach is bypassed with sort of a Roux-en-Y type procedure. And on the right is this more common sort of sleeve gastrectomy where sort of just a large portion of the stomach is removed. And I think this is the context in which there is more concern about the wasting of absorbed nutrients, and raise the question of whether or not there might be wasting in lower levels, potentially unprotective levels or reduced protective levels of the TDF FTC. So, in the data is somewhat limited, as everyone alluded to. Tenofovir from TDF PK after sleeve gastrectomy was evaluated in 4 people living with HIV. And what was interesting is there was a decrease in absorption up to about 6 months after the procedure, but then by 12 months had returned to the pre-operative levels. So some sort of transient dumping phenomenon then seemed to return, but no data in people who don't have HIV infection. And the one thing I agree that Mike said up front that we wouldn't want to do is we wouldn't want to double dose. Again, if someone were wasting, it might mitigate some of this, but there is at least one case series brought to my attention by actually one of Susan's colleagues, Al Liu, from San Francisco, who found this case series of ART cocktails that for a brief period of time did add TDF at a dose of 600 milligrams a day to a regimen. And there were at least one out of these 10 patients who experienced a Fanconi syndrome. So probably not something that we want to be doing. So that's a somewhat rarefied case. So I don't think we need to dwell on it too much, but we did, Doug, what you suggested, and we left him on TDF, FTC, and he's done fine. We tried to find commercial labs that would sort of do levels for us, and we kind of gave up on that because the complexity and insurance complications became too much. Anyway, next case is, it's a dangerous world out there. And Connie, just so you can be ready, this is coming to you. This is a 55-year-old man who comes regularly for PrEP follow-up, and all indications suggest that he's adherent to his PrEP. He has 4 to 5 male sexual partners per month. His condom use is inconsistent. He has a history of recurrent rectal chlamydia with interim documentation of clearance because of appropriate treatment. You confirmed the dates and the treatment provided. So this isn't sort of inadequate treatment. It really is clearing in its recurrent infection. So question out to the audience is, if he has one more STI, you will stop his PrEP. This is a, quote, occupational hazard of condomless sex, and leave it at that. Grow up, America, use a condom. And just so people know, this is on here because that was on a billboard that loomed over Los Angeles right around the time PrEP use was just being scaled up. So you can vote for that if you think that's appropriate. Daily doxycycline with his daily oral TDF FTC. Doxycycline 200 milligrams post-coitally up to 3 doses per week. And have his partners gargle with Listerine before oral sex or oral anal contact. Let's see what the audience thinks of those options. Mike, no music? You're on mute again. Okay. Susan, you're the one person who, Susan and Connie are both not on mute. You guys have known each other for quite some time. Didn't you do residency training together?
Yes,
Maybe you could duet for us.
Well, Susan's much more musically inclined, so I will let her do that.
I think we both know each other well enough to suggest that neither of us should be doing the musical part.
On the next question, Raphael, you and I can chant. How's that? We'll do the opening of Hamilton together.
Sounds good. Sounds good. Little known facts about Susan Buckbinder for the audience. She is a near professional quality tennis player.
Oh.
Okay. I think we can push the results out to the audience. looks like we have about 40% of people liking the postcoital doxycycline. We've got about a third of people liking daily doxycycline, and 20%, almost a fifth of people saying it is what it is if you're going to have condomless sex. Okay, so let me share my screen again and we can move on. And Connie, what do you
Sure.
think?
Well, I would not stop PrEP. This is the exact kind of person who should be on PrEP. So I think 1 and, basically 1 through 3 are not good options because I think that's not being very sex positive. 4 is not, I think, an option because we really have very, very limited data on daily doxy, and it might also increases GI side effects. So many people are probably aware for number 5 about the IPERGAY study, which did offer, did a open label study of, placebo-controlled trial of doxycycline post sex, and used up to 3 doses per week and found about a 50% overall reduction in STIs. No impact on gonorrhea, but did see about a 70% reduction in chlamydia. So that is one study that is now being followed up by several studies, including one that's in San Francisco and Seattle. So if you lived in San Francisco or Seattle, I'd say he is a perfect candidate to be in a follow-on study where we will look at doxycycline PEP and try to understand effectiveness, safety, and effect on antimicrobial resistance. If he doesn't live in any of those cities, and depending on how recurrent this is, if it's been several episodes and he had received doxycycline for his rectal chlamydia instead of azithro, he would be a case where I would consider, without a lot of evidence other than the IPERGAY study, prescribing doxy-PEP, but my preference would be to try to get more data if that's at all possible. The last one, for people who think it's a joke, there's actually some data that mouthwash may reduce pharyngeal gonorrhea, but no evidence that it works against chlamydia. So 6 is also not a good option.
Thanks, Connie. Anyone else want to chime in? Mike put in the chat that he was suppressing his desire to gargle with Clorox, and I think we all can endorse that probably is not a good idea, Mike.
Right, no, I would think not, maybe.
Okay, Doug, Susan, or Michelle, anything to add to Connie's?
I think the only thing is that people ask, is there really an increase in STIs because of PrEP? And we definitely are testing more, so we're picking up more STIs, but there probably is more. There probably are more STIs as well. But it's not, these are the challenges, that these are people who were, you want to use PrEP specifically for people who are not using condoms, and so, or are using them intermittently. And so you are enriching for a population that may be at risk for STIs. So I don't think it's particularly helpful to get into the blame game, or if you stop PrEP, that the likelihood that he's not going to get STIs. I think he just may get the STI of HIV, which is something that we're all trying to avoid.
Yeah, thanks, Susan. I think that's a very practical approach. I do find it a little bit circular when we start going around and around of, are there more STIs because of PrEP? And the answer is, well, there's less HIV because of PrEP. And, the answer seems to be we need better prevention strategies for STIs, not we need less PrEP. So I do agree that's not a useful argument to get in, and kind of derails some of the more important issues. So just getting to some of the data that Connie was referring to quickly here, the PEP with doxycycline study that Connie was referencing, of course, was part of the IPERGAY OLE study, again, as Connie mentioned, where people were assigned to this doxy post-exposure prophylaxis up to 3 times a week, a double dose, or no intervention. And as Connie mentioned, this 50% reduction in all STIs and limited to syphilis and chlamydia, no effect on gonorrhea. And what I find most fascinating about this is, yes, absolutely, we need more data to follow this up. But, if you think back to the acne literature, right, we've been using, tetracycline derivatives for fairly prolonged periods of time, for a long time. And we haven't seen, tetracycline or doxycycline resistant MRSA sort of emerge as an epidemic, or these long-term toxicities that we worry about. So I actually am fairly excited to see the follow-up results of this. And in this particular patient, even absent, good follow-up data, and of course, we're not in San Francisco or Seattle, so I did try it, and he hasn't had rectal chlamydia since then. And, this is a highly functioning PrEP patient who's able to, dose post-coitally. And, I think our most vulnerable populations probably, adding an additional complexity to taking PrEP every day probably doesn't serve anyone very well. But for some people, I do think this could be an exciting strategy. And again, coming back to what Connie said, there are some fascinating data about reducing oral colonization with gonorrhea. And it's really important that people understand this is just Listerine, Total Care, and Cool Mint. It has not been studied with the other flavors or brands of mouthwash. Does reduce oropharyngeal colonization with gonorrhea, both in an in vitro cohort and a randomized controlled trial. Whether that has anything to do with anything else, maybe, maybe not. But I mean, the oropharynx can be a source, particularly with oroanal or orogenital contact, of some infections. So I wouldn't do it in isolation, but we don't have data for it for chlamydia, which was this particular case.
There's no data on hot mint?
Say again, Mike.
No data on hot mint, just cold mint.
Hot mint, just cool mint. Sorry. Okay, last case. And this is a reference to, Bon Jovi, of course. Shot through the heart, and you're to blame. And Doug Krakauer, this is coming to you. A 19-year-old man with a history of bulimia returned for PrEP follow-up. He thinks maybe he takes his prescribed TDF-FTC twice a week, but regularly on weekends. He had 7 male sexual partners in the past month. He engages in oral and insertive anal sex. He doesn't use condoms. His 4th generation HIV laboratory-based assay and STI testing 3 months ago were negative. And he comes in because he heard there's a shot that he can take every 2 months rather than taking a pill. Can he get that? But he doesn't want to gain weight. So your best advice is you tell him he must strive for 100% adherence to his daily oral TDF-FTC. He could try TAF-FTC, T's and S's, which of course is the strategy of just taking PrEP on Tuesday, Thursday, Saturday, and Sunday. TTSS is just fine with TDF-FTC. He should drive to Canada, acquire long-acting cabotegravir and rilpivirine for treatment where it's approved, split it apart, and use the cabotegravir component for prevention. And I have a headache. Stop asking me questions. We'll push that to the audience.
Okay. So I'm not throwing away my shot.
I'm not throwing away my shot. I'm just like my country. I'm young, scrappy, and hungry. And I'm not throwing away my
shot. Yo, I got a scholarship to King's College.
Mike, Minnie Mouse is at your door.
Okay.
Okay. Polls are coming in. This is our last question. We got about 5 minutes for a little discussion, and then we'll try and get to people's questions that have been coming in. I see a handful of questions we'll try and get to. If not, we'll get back to people by email. So we have, okay, I think we can push the results out to people. Looks like we have a fairly even split at about 1/3 of people saying T's and S's is just fine and he must strive for 100% adherence. We have a handful of people who are just fans of TAF FTC and want to try and do that. So I'm going to try and reshare my screen again, and we can go back. Okay. So Doug, what do you think?
Well, I think there are a lot of health benefits to getting to Canada as soon as possible under the current circumstances. So 4 has a lot of value in my mind.
Touche,
but
touche.
We can't get across the border and we're stuck in the US of A. I think 100% adherence is great if you can achieve it, and the benefits in terms of prevention efficacy are probably maximized. But there are a lot of data from some of the earlier studies that Susan and others participated in terms of the IPERGAY OLE, showing that if you can take about 4 doses a week of TDF-FTC in the MSM population, that you probably do have close to near perfect protection. T's and S's per se has not been studied, and I think if the dosing is chaotic enough that sometimes it's just 2 doses a week or even 3, then I think that the curve in terms of prevention efficacy is not nearly as robust, and I'd worry a lot about that if you can't maintain at least the kind of drug levels that seem to be associated with 4 doses a week on average. Then I would worry that it's not a great strategy. So it's going to be an ongoing negotiation and recurrent assessment to see where we're at there. I think that in terms of challenges with adherence, long-acting injectable cabotegravir would be an excellent option if it were available. And so in the future, that would be a great option. The part of the history that might raise discussion with this particular patient who has a history of bulimia and is worried about weight gain is there was some data coming out of your study, Rafi, recently presented at the AIDS conference, that there might be a difference in terms of weight for cabotegravir versus the daily oral TDF-FTC. The difference is relatively modest. I can't remember, but it was on the order of 1 kilogram or 2 over the long haul of a year or 2. And so I think if that's a deal breaker, and that would mean that someone would say, no way, again, kind of relying on this idea of a patient-centered conversation where this isn't a one-size-fits-all, we really have to figure out where this person is at and try and maximize the PrEP benefits in the context of their life. And if the weight gain at that level is not going to be a big issue, then adherence-wise, I probably would favor something like cabotegravir. On the other hand, if that's a deal breaker, I think we could probably say he's going to get protection if he can maintain about 4 doses a week. And if that seems to fall off the curve, we have to reassess.
Yeah, all great points. The one thing that's interesting about this weight issue, and this comes up both with TAF FTC and TDF FTC, and also for cabotegravir, is the TDF FTC, both in people living with HIV and in the PrEP context, seems in the first year to have this weight loss syndrome, and unclear if that's entirely related to the GI startup syndrome that usually lasts only 2 to 4 weeks. But there seems to be this year of weight loss, and then there seems to be this trajectory that these agents all seem to follow that's fairly similar thereafter. TAF FTC, TDF FTC, even cabotegravir after the first year, it seems to be all the same. And again, cross-study comparisons being very biased and fraught. In HPTN-077, the cabotegravir weight gain over a year was not different from placebo. So, question is this just what happens as we age? Do we gain an average of 1 kilogram average a year? And I think that's something that remains sort of unexplored, but is an interesting hypothesis. Is it all attributed to that first year, and what does that mean? So I don't think we know the answer to that yet, just focusing on the weight for a second. And, this T's and S's issue is sort of provocative, isn't it? The youth population seems to have gravitated to this in a way that's a little almost inexplicable, right? It seems to have found a marketing niche that, because it sounds cute, it sounds doable. There's something about the self-efficacy associated with things that have a mantra that seem to allow people to at least be able to conceptualize how they would implement being less than perfectly dosing every day. And you're 100% right. We don't have data, but I find it so interesting from a public health perspective that, you know, we're not as good as, you know, pick your big company, Coke, Pepsi, Apple, at marketing products. You know, we don't have, you know, PrEP marketing at that sort of level to make everybody want it. But maybe this is a signal to us that we need to figure that out. Others have other thoughts on what you do in this particular case. Well, maybe we could just sort of go through some of the data, and then and people can comment as they see fit and relevant. You know, this is an infographic that Julia Marcus, who was at the Kaiser group in Northern California and now is at Harvard, made, and I find this really helpful in sort of comparing TAF FTC and TDF FTC for patients. You can find it online, and it's really, you should laminate it and keep it in your clinic for these conversations to have when people come in to talk about this distinction. And it talks about the differences in lipids and the differences in weight and a variety of other contexts. And I would point out that the TAF FTC tablet is smaller. It is smaller than the TDF FTC tablet. And there are some people for whom this is, you know, that's a big issue. So I do think we should focus on that. This is HPTN 083, the study design. It's a little complicated. The take-home point is it was a double-blind, double-dummy study where there was a 5-week oral lead-in of cabotegravir versus TDF-FTC, and then an oral injectable direct comparison that went up to 3 years, and then a tail coverage period where people got open-label TDF-FTC. And these are the primary results. And, you know, the incidence rates in both arms were very low. 0.41% in the cabotegravir arm, 1.22% in the TDF-FTC arm, 13 and 39 infections, and the cabotegravir was superior. And you know, perhaps the most interesting finding was if you look at the bottom 5 cases on this list of the 15 total cases, 13 incident cases that occurred in people who got cabotegravir, you can see there are 5 who happened despite what seemed like on-time dosing of the cabotegravir injections. So I think coming back to the questions we had earlier, it's going to be really important to understand these people have super low cabotegravir levels for some reason, what was permissive to HIV infection in these cases, and what are the resistance profiles. And we don't have the answers to that yet. The other cases are fairly easily explained. Or we hope they're fairly easily explained, but I think we need a fuller understanding of this before we, you know, are able to, you know, completely and with full information recommend cabotegravir as a PrEP agent. I'm going to skip because we're a little out of time here. Injection site reactions were the most common adverse event, but happily were infrequently treatment limiting of the cabotegravir. So, you know, someone who doesn't tolerate pain well might have issues. Other adverse events were fairly well balanced. This is the weight data that Mike was referencing and Doug mentioned. Overall, there was the statistically significant difference of 1.3 kilograms annualized weight gain compared to the Truvada 0.31 kilograms, but it was really driven by that first year of weight gain. Again, in the first year, there was this large difference, weight gain in the cabotegravir arm, weight loss in the Truvada arm, but after a year, it was really equal. Both gained about 1 kilogram per year. So that's all the cases. I want to thank our panel. Let's look very quickly at the questions that have come in our last couple of minutes together. The question about our first case was the patient with chronic kidney disease. Should we have started him on TDF since he already had CKD? So this is a little bit of a biblical conversation. You know, TDF-FTC is approved down to a creatinine clearance of 60. And, you know, TAF-FTC is approved down to 30. Whether or not someone with risk factors and a perhaps borderline creatinine clearance, whether or not they should go immediately to TAF-FTC versus start on TDF-FTC with closer monitoring. I think different clinicians have different approaches to this. But, you know, certainly he's at risk for progression of his renal dysfunction from where he was starting from, as Susan mentioned at the beginning. With the case of bone loss, what about treating his osteoporosis? Vitamin D and calcium might not be enough. Absolutely. And I think it was Susan or Connie who mentioned that he may need additional interventions before for even addressing the PrEP question, and I completely agree with that, and that's why he's being followed by an endocrinologist. And I think our endocrine colleagues will be really helpful in situations like that. A 35-year-old male clearly has something going on that we'd want to address. Let's see, PrEP in a renal transplant patient. Again, obviously lots of nephrotoxins probably in the mix there, lots of reasons to be concerned. I don't think we have any data for TAF-FTC in that population yet, probably very limited information about TDF-FTC. I'd probably start with TDF-FTC and watch closely. That would probably be my approach. Thoughts on using the URSure test, not just for PrEP adherence, but to assess absorption in an individual status post-gastric bypass, ulcerative colitis, or Crohn's. I think we need a lot more experience before being enthusiastic about recommending the point of care testing. Personally, I'm most excited about Monica Gandhi and Matt Spinelli's urine EIA test that's in development as a point of care test because of its performance parameters. But let's sort of see how to utilize these point of care tests. I think they could be very exciting to support adherence in the future. Bariatric patients at huge risk for bone loss due to absorption issues. How did that affect your choice? Great question. I think we'd want to make sure that the bariatric specialists are guiding us on how to monitor such patients. And if you're concerned that there is a risk for more bone loss, you could consider using TAF-FTC up front. Again, how much to use TAF-FTC anticipatorily rather than waiting for evidence of toxicity, again, is a little bit complicated. You might be more excited to do it with the bones situation because it's a clinical test that we do less commonly than is routine monitoring for renal dysfunction. A rhetorical question, why are all of the cases men? Absolutely great point, and I need to make some of them women or transgender individuals. Thank you for that comment. Would you consider doxy prophylaxis with PrEP if a history of recurrent syphilis as well as rectal chlamydia? Yes. You know, the data that Connie pointed out and that we reviewed showed a 70% reduction in syphilis as well. So I think we need follow-up data before we can recommend it as a general practice. But I think if they're in Seattle or San Francisco, enroll in Connie and Annie Lukemeyer's study, and otherwise, you know, you could consider it on a case-by-case basis. Let's see. What else? Any new prevention trials coming down the pipeline to include persons who inject drugs? Do we know how 211 strategies might apply in this population? We need more data. I'm not aware of any studies currently in the field, but we certainly need more data. And preemptive use of bisphosphonates in older patients on PrEP or even ART. I don't know. I'm not aware of any data to support that, but it's an interesting question. I don't know if anyone else knows of any data in that domain. Okay. We're a little bit over, so I apologize for running over, but I want to thank our panel for really an exciting and vibrant discussion, and thank you all for the great questions and thoughts, and hopefully that was fun and interesting, and thanks for sticking with us to the bitter end here of the day. Thanks, everyone.
Thank you.
Thanks.
Thank you.
Dr. She got pulled out of the meeting, so I will move to the closing slides here. Thank you all very much. Great job, Rafi, and your cat participated in a stellar way.
I apologize, everyone. Dr. Ian Dorio's on her way back. She'll be back in just about 15 seconds.
Okay. Reminder, while we're waiting for her to come back, to everyone to fill out your evaluations. It's very, very important, and we're looking forward to seeing what your comments are, and then and look forward to seeing you again tomorrow. It looks like her slides are up. I'll turn it over to her.
Thank you so much. Appreciate it. So we have some information from, again, thank you to Dr. Shiver and Dr. Sag for being co-chairs of this conference. We have some engagement summary slides from yesterday. So really exciting how much participation we've had this year. So attendee logins yesterday, 594. And you can see from the live stream views how many people watched real time and voted during the audience response questions and completed the evaluation and looked at the resources quite a lot. So we really appreciate that you're all not only listening to these sessions, but actively participating. And today we've had more than 650 people logging on. So we're really excited about that. Please remember that evaluation is really key. We want to hear what your comments are about how to make these sessions better for you in subsequent years. So you can go to the evaluations tab. If you start on a daily or overall evaluation and you're not able to complete it in one sitting, you can exit and re-enter if you use the same device. Otherwise, you have to restart over again. So the case presentation slides were not available real time because we wanted the sessions to be truly interactive and spontaneous, but they will be available, and on-demand webcasts are available on the platform about 24 to 48 hours afterwards, and you could see this link here. The conference that's happening simultaneously is the Ryan White Conference on HIV Care and Treatment, and the opening session will be available to all of you who are participating. If you've separately registered for the Ryan White Conference on HIV Care and Treatment, please participate in the conference and including the opening session using that particular login. But if you've not separately registered, feel free to use your clinical Ryan White login. So we look forward to your participation tomorrow. We'll see you 7 a.m. Pacific, 8 a.m. Mountain, 9 Central, and 10 Eastern time. We look forward to seeing you all. Be safe and be happy, and we'll see you then. Thank you.